welcome everybody to this WONCA webinar on mental health in the time of COVID. We did another one a few months ago in April. I hoped we'd never have to do another one, but we absolutely do, because these problems are still with us. But I'm delighted that we've got a very, very impressive panel of people who are going to talk with us this morning and give us some insights and some advice and some wisdom about how we help our patients and help ourselves in managing our mental health at this very difficult time. But first, before I introduce the panel, we want to show a little video from our WONCA president, Donald Lee, who is welcoming everybody to this series.
Good morning, afternoon, evening. Thank you for taking time during your busy schedule to attend the second series of WONCA webinars. Family doctors around the world have risen to the challenge of this awful pandemic. In the midst of the massively increased workload for family doctors, I'm proud of the level of support and collegiality displayed within and across our member organizations and from region to region. It is heartening indeed. Indeed, the COVID-19 pandemic is bringing a lot of changes to our professional and personal lives. We are slowly adapting to the use of technology to overcome barriers and challenges created by the pandemic. We are getting used to meet virtually and using the cyberspace like what we're doing now. Colleagues are disseminating scientific advice, clinical updates, reflective messages, and professional support through their social media links and connections. They're keeping in touch with each other regularly, like family members, relaying information, urging courage in these extraordinary times. I think all those who participated or listened in our various webinars held in June and July will agree they have been well received and appreciated by many family doctors around the world. I'm really looking forward to the next series of webinars, which will include presentations from our working party and special interest groups on health equity, women and family medicine, e-health, aging and health, complexities, mental health, palliative care, adolescent and young adults, as well as the environment. Before I hand it over to the convener of this sub-webinar, I would like to say that unfortunately, this is a pandemic with an unknown endgame. I wish each and every one of our family doctors well during this time. Use the best advice available, work collaboratively with your teams, do the best you can for your patients. You should stand proud of your contributions in facing the world crisis. No one knows what will be ahead of us in the weeks, but everybody knows enough to understand that COVID-19 will test our capacities to be kind and generous, and to see beyond ourselves and our interests. Our task now is to bring the best of who we are and what we do to a world that is more complex and more confused than any of us would like it to be. May we all proceed with wisdom and grace. Thank you.
Thank you, Donald, for those very wise words. Okay, I'm going to introduce now the first of our speakers. So we've got four speakers. We've got first of all Juan. I'll come back to in a minute. He's going to give evidence from the front line of his work with patients in Barcelona. And then Weng Chin, previously from Hong Kong, now in New York, is going to talk about non-drug interventions. And then Kim Griswold from New York State is going to talk about the physical health care of people with severe mental illness. And finally, Jill Benson from Adelaide in Australia is going to talk about how we look after ourselves. There's opportunities for those of you, whether you're on Zoom or on Facebook, to post questions, comments, and queries. We may be able to deal with some of those as we go along, and if we can't immediately, we'll certainly get back to you in the next day or so with our best possible responses. So first, I'd like to introduce my good friend and colleague Juan Mendive from Barcelona. As you can see from the screen, he's a family physician. He's been working in depth with mental health for years, and over the last few months with mental health in the time of COVID. And I think he's got some very helpful insights into the sorts of problems people are experiencing and what family doctors can do to help them. So Juan, I'll pass over to you.
Good morning, everyone, and thank you very much for this kind invitation. Thank you, Chris, for your words. Yes, I'm a family physician working in the outskirts of Barcelona in a deprived area, and I've been working during this pandemic time all the time in trying to provide the best services possible in this very, very difficult time. Next slide, please. So I'm going to show you my views on what COVID-19 is providing threats that impact really on mental health. And the reality because of that is for different reasons. This is like I want to show them the unknown virus behavior. They are certainly about unsafety, fears for family and friends, bad news on news day to day, feeling of lack of control, feeling that there is no end. So there's very, very diverse difficulties that people have to cope. And as you can see in this slide, from protection to management to training and coping in primary care. So there's various issues that are very changing a lot our way of working during this pandemic time. And next slide, please. So I'm going to see in different scenarios that I've been actually witnessing during my time in primary care all these months, that I've seen people who are on long-term already management, or either from primary care or mental health units, who are actually having difficulties in follow-up, either on a virtual way or practice appointments, or because COVID-19 have induced psychological or psychiatric symptoms. We also have patients, all of us, who have developing new onset of mental health conditions because of difficulties and different stress issues during the pandemic. So there are very, very diverse scenarios that we have to cope as primary care doctors. And I'm taking some of my own patients that are real ones, and I'm going to show you quickly some of my experiences with them. Isabel is a 45 years old lady, and she's divorced, lives with mother and two sons, and she usually works as secretary in an insurance company. Usually have a bit of stress, but coping with exercise and relaxation. She has a handicapped mother, 18, advanced osteoarthritis, and she can't move. And she needs a person to look after her every day. Next slide, please. During the pandemic, the insurance company sent Isabel home for teleworking. Mother's caregiver stops coming home for quarantine, and Isabel had to work and look after her mother. So once she phoned me in the practice after 3 weeks or so and said, "I can't cope, doctor." And she starts explaining me about her stress, and she was in tears. She felt guilty because she couldn't sleep. And actually, what I decided with her is to send her a sick leave form and provide her with emotional support and stress coping techniques that hopefully make her feel better after 2 weeks of follow-up. This is a very usual situation that you can all experience in primary care. We also have Frank. He's a 52 years old man. She's also divorced and married again, lives with second wife and two sons. He moved to Barcelona 2 years ago from another country, and his only son remained there. He's a lawyer working in a law firm, and he actually had anxiety in the past when got divorced, but is stable now. He remembered have had phobic symptoms in the past that made him even difficult to leave home at that time in the past, but hopefully he was okay now. Next slide, please. But the pandemic made Frank started that he also went home for teleworking. So at first he started having fear. Afterwards, real panic, panic of being infected, panic even of thinking about leaving home, of going out. So when fear again asked him to come back to work after the pandemic started a bit better, he couldn't really. and he need also a sick leave. He explained really big panic attacks several times, even short of breath and sleeping difficulties. So we arranged to put him on SSRIs, and I did some follow-up visits. At least one of them hopefully was in practice where we could have a different perspective of managing. We also have Sophia, a 42 years old lady, married and mother of one girl, working in a clothing store in Barcelona. And she has a history of long-term chronic depression. Hopefully she was stable during the last 2 years. During these couple of years, she was also diagnosed with fibromyalgia. She's very reluctant to have psychopharmacology. She actually doesn't want any pills, as she usually says that pills make her feel bad. She's active in yoga, mindfulness, and physical exercise that really help her a lot. And usually I do provide her with follow-up visits to provide with emotional support. But the pandemic provide a big problem to Sophia. Next slide, please. Sophia phoned me to ask for a face-to-face appointment. She thought that things were going bad. She explained her starting feeling bad for the lockdown and feel depressive symptoms again, mainly anhedonia, low mood, difficult to sleep, and loss of energy. When going to work, also general pain because of the fibromyalgia symptoms, and even explaining symptoms of smelling hydrocolloid liquids everywhere. And that was actually quite new. So also she was having panic of being infected, and even that couldn't breathe properly wearing the mask. So I provide her also with a sick leave and non-pharmacological support with her agreement. Next slide, please. And my last scenario I'm going to show you, my last patient is Jose. He's 82 years old man. He's a widower, lives alone, has 2 daughters, and live nearby, and also have 5 grandchildren. He used to go every day to a community center for elderly people, where he joined other people and friends for activities, and also usually he used to have lunch there. Jose has been COPD and suffered of a myocardial infarction about 5 years ago, and he's on different pills, including treatment for hypertension, diabetes, and pain relief tablets for advanced osteoarthritis. Next slide, please. During the pandemic, the elderly center was closed. Jose's daughters and grandchildren couldn't visit him because of the risk of COVID infection. On a follow-up telephone appointment, he explained being in a very bad mood, fell down, lost appetite, and couldn't sleep well. He cried on the phone saying he should die to join his wife. All that happened in spite of his daughters phoning him regularly, and a social assistant was taking me. So poor Jose actually was having a very bad time, and he only remembered being like that when his wife died. So he was put on a low dose SSRIs and had a follow-up face-to-face appointment also to check cardiovascular profile. In spite of a mild improvement of mood and that the cardiovascular profile from him was quite well controlled, unfortunately, he suffered a mild stroke some weeks afterwards, and hopefully he recovered well after that without deficiencies. Next slide, please. So this is what I would like to show you quickly, what I can actually say that is the holistic approach of COVID-19 and health impact. We have seen in these different scenarios how COVID-19 can make an impact either through the physical, psychological aspects, providing anxiety and depression. That is our main focus of presentations today. But also we do know that there are very important links on the biological aspects, as we have seen with Jose, and even with the social, including family and community aspects. So all that picture, all that is part of the same person, and their relationships are always very, very important together. Next slide, please. So there are a lot of publications during this time already about how COVID-19 impacts on mental health. And I will just show you this, that was published in the International Journal of Social Psychiatry recently, about how to address psychological stressors and the importance to include all patients that may have impairments because of that time, and also the importance for from media and social networks to provide supported interventions, to be about not provide wrong messages, but try to also help people to be supportive in the psychological intervention. Next slide, please. Finally, I would like to know, to explain you how primary care mental health in COVID can be actually involved. So we need to follow up patients on risk. So we do have patients already under depression and anxiety that may be sometimes support, like the ones especially with past phobic disorders. We need to follow up patients that have been suffering from COVID, especially those ones who are having had time in hospital. Also to follow up their stressful conditions not well addressed because of the lockdown. And even the mourning for relatives or friends, for instance, have been very big, important disasters for many people. And to be sure about the unprofessional, emotional, and psychological situations that are having a real impact for us. And we have to search for help for us if necessary sometimes. Next slide, please. And I would just finish with this. We should try to look for coping resources if necessary to help us, even helplines for professionals that are available in many places, and also a web page aimed to people to try to help them and cope with COVID stress and other problems during this pandemic time. And this is a picture of my practice. And thank you very much for your attention. And I'm open for questions if necessary.
Juan, thank you very much indeed. That's a very helpful introductory presentation. I really appreciate that. And just to say, if you're watching this live or watching this later on, you'll be able to pick up all these resources and look at them at your leisure later. So if people have questions for Juan, can you put them in the Q&A either on Facebook or on Zoom, and we'll pick them up live if we can, or if not, we'll answer them. We'll answer them very soon. Okay, so thank you for that. I'm now going to move on to invite Weng Chin to do her presentation. Weng, we first met when she was doing her doctoral work in Hong Kong, and she's now moved to New York, and she's done some very, very important work for WONCA on this particular topic of non-drug interventions. You may have seen this on some of our websites before, but this is a wonderful opportunity to talk about things that are very, very, very relevant to our daily work. For the sort of patients that Juan was talking about are exactly the sort of patients that benefit from the things Weng's going to tell us about. So Weng, I'll pass over to you.
Sorry, I always forget to unmute. So thank you, Chris, for that kind introduction, and thank you everybody for joining this webinar. I am going to present some highlights from a WONCA guidance document that was developed by our working group a few years ago, which summarizes some techniques that can be incorporated by any family doctor into just their routine 10 to 15-minute consultation to help patients who may be experiencing psychological distress. So the COVID-19 pandemic and the resulting economic recession have negatively affected many people's mental health and created new barriers for people already suffering from mental illness. And as this pandemic has worn on, ongoing public health measures are exposing more people to situations that lead to poor mental health, such as social isolation, loneliness, and job loss. With limited access to mental health care and pre-existing shortages in mental health specialists, all this is being made worse by this pandemic. Next slide. So what can the family doctor do? The UK NICE guidelines advises using a stepped care approach with two key principles. Firstly, treatment should be evidence-based whilst minimizing the burden or harm to the patient. And secondly, scheduled reviews. This is going to help you enable the stepping up, stepping down, or even stepping out of any treatments. And NICE recommends using non-drug interventions as the first-line treatment. Next slide. I would like to introduce you to the WONCA non-drug intervention, or NDI, toolbox for family doctors. This consists of supportive and empathic communication techniques and modified brief evidence-based therapies. The interventions are transdiagnostic. In other words, they can be used for any common mental health disorder, depression, anxiety, panic attacks, and they can be effectively delivered by non-mental health specialists. This includes primary care doctors, nurses, and even trained lay helpers. You'll see there is an orange box at the bottom of each of my following slides. And these are links to references on the various techniques I'm going to be talking about, or to online resources which can form part of your NDI toolbox. Next slide. Firstly, let's talk about how we can express empathy and provide support or encouragement in the way we interact with our patients. Now, family doctors are very good at building rapport and a therapeutic alliance with our patients. And most of you are probably using these techniques already without knowing. These include empathic listening, such as nodding and the appropriate eye contact, providing positive affirmation, this is giving praise, such as, I can see how hard you're working. Helping to reframe a problem. So in other words, by helping the patient see that maybe the problem as an opportunity, or by use of normalization to let them know they're not alone in this situation. And this helps to validate their emotions. Sometimes by facilitating the patient to let go or give in, particularly like letting go of a grudge, you can say something like, you know, you've got to choose your battles. Maybe this one's not worth it. And finally, and by no means the least important, especially during COVID, is by correcting misconceptions or misinformation, which may be causing stress. So the Bathe technique is a psychotherapeutic intervention designed to fit smoothly into a routine primary care appointment. It uses an interview format to allow the doctor to assess the background situation, the patient's affect, the problem that is most troubling for the patient, and the way the patient is handling the problem, and concludes with a response that conveys empathy. Next slide. Psychoeducation. These are educational interventions that empower patients to improve their mental health. It helps reduce stigma, self-blame, and barriers to treatment. Now, the current evidence suggests that whilst the quality of the information provided is important, the method of delivery appears to be less important. So for the busy GP with time limitations, you can still provide psychoeducation by referring patients to books, websites, or patient education leaflets. Next slide. So stress management and relaxation techniques are useful clinical skills for all family doctors. These interventions can be used for people who are sick or under distress, but are also useful for healthy individuals for health promotion. They can improve quality of life and contribute to the reduction of physical and psychological symptoms. And it's also therapeutic for healthcare providers ourselves. And Jill Benson will talk more about building our resiliency to adversity. Next slide. Behavioral activation is a therapeutic process that emphasizes planned activities that aim to increase behaviors that are likely to produce improvements in thoughts, mood, and overall quality of life. It's actually one of the behavioral components of cognitive behavioral therapy, or CBT. The aim is to structure in positive distractions and mood improving activities. So increasing activities that bring pleasure, enhancing social interactions, promoting better sleep, and improving self-esteem. Next slide. So exercise on its own or incorporated into a behavioral activation activity plan should also be promoted routinely by GPs. Studies have shown that exercise can be as effective as psychological or drug treatments for reducing symptoms of depression. And exercise can have benefits for mental health, even if it is light, such as yoga and stretching conducted just once a week. So the takeaway message regarding exercise and mental health is that something is better than nothing so long as it's done regularly. Next slide. A quick word on CBT, cognitive behavioral therapy. Traditionally, this has been provided by psychologists or mental health therapists, but a number of systematic reviews have now shown that online or iCBT interventions are effective and provides an important alternative to face-to-face psychological treatments, which may be difficult to access during COVID. One of the greatest barriers limiting the effectiveness of these online interventions, however, is actually compliance or adherence. So what we call guided iCBT, in other words, where the patient may receive nudges, reminders, or check-ins with their GP or an allied health staff, can increase their efficacy. Next slide. So I have covered a lot of content in just these last 10 minutes. So if you are looking for more information, please see the WONCA website link below for our full NDI guidance document with all the references and even additional toolbox links, as well as our recently published Global Primary Health Mental Health Care available through Routledge. The WONCA NDI guide and toolbox is available on the WONCA website and is available in English, Spanish, and Mandarin. So it's a very useful tool. Please take your time to refer to it. Finally, I would like to acknowledge everybody who contributed to the NDI guidance document. And next slide. Here's my email if you would have any follow-up questions that you would like to direct to me directly. Thank you very much.
Weng, thank you very much indeed for a very clear, very succinct summary of some important work that you've been leading on. Just by the way, we've got a colleague who's producing a Vietnamese version of this, so we'll let you know about that in a few months' time. So when that's developed. Again, if you've got questions, one or two questions were popping up on Zoom, but questions on Facebook and Zoom, we'll pick those up now if we can, and certainly later on if we can't do them straight away. So Weng, thank you. And I'm now going to move on to Kim Griswold. Kim's been working, Kim's from Buffalo in New York, and she's been working with Alan Cohen from London, again through WONCA for several years, looking at the physical health care of people with severe mental illness. And that's something which has sadly been neglected and is extremely important in terms of not just quality of life, but quantity of life. And has never been more significant than it is right now with the risks from COVID, as you know, going back to the example of Jose that Juan was just talking about a few minutes ago. So Kim, I'll pass over to you now.
Thank you so much, Chris, and welcome everybody to this webinar. I'm a family doctor. I currently research the mental health needs of refugees and asylum seekers. In this presentation, Alan and I highlight the essential role of primary care for people with serious mental health disorders. Next slide, please. As you've heard already, COVID challenges primary care. And I think it requires us to hold on to our goal of parity between physical and mental health and find ways to identify and support patients in the months ahead. People with serious mental illness in particular often have difficulty accessing primary care, so we must be ever mindful of that. For this presentation, serious mental illness implies a diagnosis of schizophrenia, bipolar disorder, or other psychotic disorder. The disability is significant, and the duration of the disorder is usually at least about 2 years. Next slide, please. And I think the imperative of the Millennium Sustainable Goal 3 is particularly important for our patients with SMI. We must reduce premature mortality from non-communicable diseases through prevention and treatment and promote mental health and well-being. In individuals with SMI, reducing premature mortality is particularly important. Their morbidity is often due to physical health problems, diabetes, hypertension, cardiovascular disease and metabolic disorders, and tobacco and other substance use. The pandemic has grave effects on mental health. Just recently, WHO did a study and found that the COVID-19 pandemic has disrupted or halted critical mental health services. Critical mental health services in 93% of countries worldwide, while the demand for mental health is increasing, as you've just heard. The survey was of 130 countries, and it provides the first global data showing the devastating impact of COVID-19 on access to mental health services, underscoring the need for increased resources. The other effects on mental health include decreased access to medications, increased symptomatology, as you've heard, increased incidence of anxiety, PTSD, and depression, and a rise in substance use, domestic abuse, and intimate partner violence. Next slide, please. It has concomitant effects on the physical health, which are so important for our individuals with SMI. There's been a reduction in care management for the critical conditions that cause physical health problems. There is obviously decreased access to care, and in individuals with serious mental illness, they often do not have access to telehealth and may in fact have problems accessing medical care. One study has shown a decrease in rates for testing of LDL cholesterol and hemoglobin A1C, so more difficult to follow our patients. And there's been a decline in new medication prescriptions. This study showed a decrease in the prescriptions for statins and metformin, clearly needed drugs for individuals with those conditions. Next slide, please. The importance of the family doctor and team has been shown clearly through all the evidence so far. We provide the frontline care to people with SMI, particularly because there is a dearth of psychiatrists worldwide in hard-to-reach areas. We have heightened awareness of COVID-19 effects on both physical and mental health, and we remain the pillars of robust primary care systems, needed more than ever for expertise in preventive care. Next slide, please. The Primary Healthcare Performance Initiative reminds us that primary healthcare is the foundation for health, well-being, and equity at every stage of life. Essential for mental health care, a safety net for vulnerable populations, and the foundation for equity. And we have seen equity in stark relief around the world with COVID. Dr. Lee reminds us that family doctors empower our systems of care through training and modes of practice, and that we remain the gatekeepers for optimum physical and psychological health. Next slide, please. Most urgent, I think, is the investment of resources for primary healthcare systems during and going after COVID-19. It's particularly essential for people with serious mental health issues to ensure care for their physical health. Next slide, please. I often try to find literature that can lend perspective to current issues in our world. And oddly, there's a dearth of literature around the pandemic in 1918, perhaps because of the war at the same time. There's one work that I found very compelling. It's a novel, They Came Like Swallows by William Maxwell. Mr. Maxwell is an American novelist, and this novel is about a family in 1918 experiencing the pandemic and the psychological issues of one of the children of the family. And Maxwell takes for his preface a poem by Yeats. And I just want to read a small portion of this. They came like swallows and like swallows went, and yet a woman's powerful character could keep a swallow to its first intent. And half a dozen information there that seemed to whirl upon a compass point found certainty upon the dreaming air. I think what this meant to me was that, as we've heard, this is a time of great uncertainty and powerlessness and vulnerability. And if we can come together to find certainty and stability, I hope that that will help to give us and our patients peace. Thank you.
Kim, thank you very much indeed. That's very, again, a very important presentation, and I love Yeats as a poet. I haven't read that book yet, but I will do so now. So thank you for that. Okay, so as I said at the beginning, we're hoping that we're giving you some advice and guidance on managing the needs and the care of patients with mental health problems in various different ways during the pandemic. But we also, in order to do that, it is essential that we look after ourselves. If we are not well, if we are not in good shape, we can't offer anything of any use to anybody. I'm delighted to introduce a friend and colleague, Jill Benson from Australia, from Adelaide, who is going to give us our final presentation about building resilience to adversity. So thank you, Jill.
Thank you, Chris, and thank you everybody for coming to this, and thank you to the wonderful panelists. I'm a GP. I've been a GP for 40 years. I work in the remote desert area in Western Australia, and this is a picture I took after the rain. In Australia, we have large amounts of desert that look like desert, but after the rain, they're resilient. I also work with Aboriginal people who are some of the most resilient people I know, who have suffered a great deal of adversity, and I acknowledge that I've learned so much from them. This presentation has been put together with the help of the WONCA Working Party for Mental Health. We wrote an article that we're trying to have published about how to stay psychologically healthy in the face of adversity, and the Doctors Health SA, which is a service for doctors that I work with. So if we think about what the pandemic looks like for us as doctors, we know that it's stressful. My definition of stress is when the outside circumstances are too overwhelming for our personal resources, and for most of us, that's what this is like. There are a lot of different outside circumstances coming at us, and we don't have the personal resources. We don't have the infrastructure in a lot of countries to deal with what's happening. This has left us in an environment that's uncertain. We don't know what happens the next day. Even in Australia, where we have limited COVID-19, the lockdown and the state boundaries and even the smaller areas in a state boundaries have made life very difficult for many of us. I can't actually get to Western Australia and have been doing telehealth since March because the border between South Australia and Western Australia has been closed. This has meant that often our usual structured environment has become quite chaotic. We also have insufficient training because there isn't training in what we're doing. In Australia, as I'm sure in many other parts of the world, the personal protective equipment has been lacking in many of our areas, which has left us very vulnerable. The resources, the nurses, the ventilators, the intensive care beds, the contact tracing, all those sorts of things are also limited, and there are no guidelines because this is all new. And then there's the dreaded four-letter word, time. We often don't have enough time, even before COVID-19, to deal with the things that are coming at us. But now I think it's much more difficult. Having telehealth means, it feels like it means we should have more time. But I found that I have less time. The expectations change. And then there's us. There's the fear we have for our own health. There's the fear we have for our families, the fear for our patients. There's the guilt that we're not able to see them personally, that we're not able to do enough. And for a lot of us, there's loneliness. There's loneliness when we're in quarantine. There's loneliness because we're not with our colleagues, we're not with our patients, which for me as a family doctor is one of the things I love about being a family doctor, that interaction. We're away from our families, we're away from our friends, We're away from the WONCA Working Party for Mental Health because we can't have meetings. There's the conflict we might have, the conflict with people who have different ideas about what COVID-19 means, different ideas about personal protective equipment, different ideas about how we should protect ourselves. And in a lot of places, there's a stigma. A lot of doctors have suffered because they are exposed to the infection a lot more than their families are. And people are afraid that doctors are going to be carrying the virus. For us, we have that tension even more than we normally would between our family that we want to protect, that we want to spend time with, and our work that can feel overwhelming. And for many of us, our roles have changed. We've gone from being face-to-face doctors who put our hands on every patient to being somebody who's just working on a screen. This has often done terrible things to a lot of our finances because for those of us who work in a fee-for-service, we're not able to get the same fees for telehealth. So from a doctor's perspective, this is difficult. In Australia, 70% of healthcare workers said that COVID restrictions had had a negative effect on their well-being and their family life. We know that as doctors, we're a bit like passengers on an aeroplane. We're told to put our own masks on first before we put our masks on our children. We need to look after ourselves because there's good evidence that says if we don't look after ourselves, the quality of care that we give is not optimal. We know that we have the same risk of mental health disorders as our patients do. We actually, in many countries, have a higher risk of substance misuse because we don't ask for help when we're suffering from mental health issues, and we turn to alcohol, we turn to other substances. We have a much higher risk of burnout, one of the highest of any profession. We are more likely to suffer burnout at this time because the things that keep us safe are not accessible to us. Our families, our ability to know what we're doing, our ability to have time out. We have a higher suicide rate as well. We need to look after ourselves. We need to look after each other. This particular study showed that most doctors don't ask for support from other people, but we do talk to friends, and we need to continue to do this. I'd like to talk about how to look after ourselves using these 5 principles of self-care: preparation, protection, professional promotion, and pathway of care. It's us that needs to do these things. Next slide, please. So if we think of preparation, we know that this is not going to go away. This is a marathon, it's not a sprint. And as with any marathon, we need to prepare properly with the things that we would do for any marathon. We need to make sure we're getting enough sleep, good diet, enough exercise. We need to do the things that Weng Chin was telling us about. We need to make sure we're able to dial ourselves down after one of our very chaotic and uncertain and difficult days. So we need to spend time doing meditation or mindfulness. We need to make sure we have good information, that even in this uncertain time, the information we have is the best we can have, and decrease our exposure to the difficult things that we struggle with that are mostly on social media and news. Even though it's hard, we need to spend time with friends. We need to spend time with friends physically distanced. We can do it over Zoom. I have a Zoom book club. We still very rarely talk about the book, but we talk about all the other things that we talk about at normal book club. We need to laugh. Laughter is one of the great protectors of our mental health. And it's turned into a very serious world. Zoom tends to be much more serious than real life. We need to try and find the humor in our lives. Pets are, of course, very useful, and we need to find those things to be grateful about. Not big grateful things, because sometimes they're hard to find. The small grateful things, the small things that make us laugh, the small things, the friends who leave flowers on our doorstep. Can we just go back to the previous slide for a minute? I just want to talk about this picture. We want to find times when we're like this dog, with our brain just being in this present moment and not full of all the worries that we carry around. Next slide, please. So we want to protect ourselves. Oh, my sign didn't work. So we want to make sure that we protect ourselves physically, that we're doing the things that we tell our patients to do, that we're finding our PPE, we're having our flu vaccines, we're using our masks. For those of us who are working from home, it's much, much more difficult to have that boundary between work and home life. This is a sign that one of my friends put on her door when she was trying to work at home with her supervised young children who knew that their mother was at home, but were constantly interrupting her. So she put this sign on the door to try and encourage them that she was actually a doctor working, even though she was still looked like their mother. We need to make sure that we're protecting ourselves from the overwhelming needs of some of our colleagues and friends, that we're not answering every call, that we're making sure we do put our safety masks on first, that we go to our balanced groups, we sing, that we do the things that we would normally do to the best of our ability. Next slide, please. We often get caught up in all the different things and we want to do our best. As GPs, as family doctors, that's what we're trained to do. But it's difficult when there's so many things that are outside our control. We need to make sure that the information we have is evidence-based, and that's different every day. We need to make sure that we continue to have that growth mindset, that we're learning all the time. We're learning about ourselves, we're learning about our colleagues, we're learning about this virus. We're actually learning new things about how communities can function. We're learning new things about how we can function in times of adversity. We have survived, all of us, up until this moment. We've all had times in our lives that have been difficult. We need to find the skills that we've used in the past and bring them to this present situation and use them again. We need to stay hopeful because we know that hopelessness is more infectious than COVID-19. When we work in teams, hopelessness can completely infect a team, which of course will affect our patients and our communities. The precious sparks of hope that we carry around are very, very important. Know our limits, know that we can only do so much. We especially need to look after ourselves. As doctors, we're often guilty of what's called presenteeism, which means we go to work when we're sick. This is a time when we're not to go to work when we're sick. We need to stay home for lots of reasons to look after ourselves. Next slide, please. This is a picture that I really like. It's a picture of lions in a foreign environment. They're in the snow. This is not where lions usually live, but they're together. They've found their tribe. We need to find our tribe. We need to make sure we know who they are, that we're supporting each other in that tribe. As doctors, we're often leaders in the community. As senior doctors, we're often role models for the junior doctors. As well as looking after ourselves, we need to look after those other people. We need to make sure that we do have people that we can talk to, but that we maintain that hope, that leadership, and that role model for our staff, for the people we come across. We need to maintain those core values of transparency and accountability and collaboration that we know are part of what we do. We need to find ways to be compassionate with ourselves when things go wrong, to be kind to ourselves, to make sure we're doing those things for ourselves that we do for others. Next slide, please. We also need to make sure we look after ourselves as people. We need to have doctors that we can go to look after our physical diseases, to look after our mental health. In Australia, we encourage everybody to have their own GP, and we have training for people who want to be doctors for doctors. I put that link at the end. This is me working at my doctor's health service, where I see doctors, only doctors and medical students. We need to know that the person who's looking after us as a doctor has all those things we want. They have the skills we want. They treat us like a proper patient. They value our opinions, but they still manage our care properly. That they maintain confidentiality and professionalism and all those sorts of things, but also that they can advocate for our well-being in a way that we can't. Can I encourage you all to find somebody in your life, in your country, in your place, who can look after you? Next slide, please. So in conclusion, for many of us, this is the first time we've had a crisis like this that has been so disruptive to our personal lives and our professional lives. For many of you, your resources were already extremely stretched, and this has stretched them even more. Your compassion was stretched, and you're at grave risk of compassion fatigue. Your resilience was stretched, and you are at grave risk of burnout. We need to make sure we're looking after ourselves. We need to make sure we're looking after each other, because after this is over, we might crash even then with what I've called post-corona stress disorder. That's a mixture of burnout and vicarious trauma and exhaustion and fatigue and loneliness and all of those things I've talked about. We need to make sure we're trying not to allow this to happen, because hopefully on the other side, we'll find good things. We'll know that our relationships are hugely important. We'll find those small things that we've managed to stay hold of at this time that we're grateful for, and we'll keep hold of those precious things. We'll find that we've got new strength, new courage, and new meaning in our lives, and that we have a deeper awareness of who we are in this huge, huge world, and a deeper respect for our place in that, and a respect for each other. Thank you very much.
Jill, thank you. That's just a wonderful finale to a really high quality set of presentations. Thank you. And I love what you're saying about hope. That's just so important that we remind ourselves and keep hold of that. So thank you. And so thank you to everybody. Thank you to Juan, thank you to Weng, and thank you to Kim as well for your very thoughtful, very wise presentations. We've got a few minutes. We've got 5 minutes or so. So we could pick up sort of one or two of the questions that were coming up. So Venetia, thank you for your comment. I'm glad you thought that was wonderful. Rick Botello's been putting several questions up on screen. And the one I'm looking at the moment is about the interrelationship amongst COVID stress, strain, and resilience. He says one can have high stress and resilience and low strain, or we can have low stress and resilience but high strain. And can we speak about the benefits of using the principles of positive psychology? Rick, I think that there's enough in that for 5 or 6 hours discussion, but I think I might just ask the panelists if they've got any thoughts. Juan, if I can start with you, because I know in your work you're very interested in the social elements of medicine. So would you like to pick up any of those things? And then I think I'll go through everybody in turn, actually, but I'll give you a chance to start.
Thank you very much, Chris, for giving me this opportunity, and thank you, Richard Botello, for these questions. Actually, I try to explain that they use normally the generic techniques we have been explaining in the non-pharmacological interventions, and especially I'm quite familiar with psychoeducation and the Bathe technique. And so I know that for some situations like the ones you are explaining here about explaining family dynamics of COVID anxieties, dilemmas and stresses, and how management of contact issues can be done through these generic tools. But to be honest, I think it's a question of facing the situation in a very open-minded way, in which we just try to be as empathic as possible, try to be in this time of uncertainty, trying to explain things as they are, and we don't have actually some answers that are very difficult to answer. But if we try to feel open mind, if we try to be honest, if we try to be transparent and human, I think people understand very well. And so in this way, I think we are very well perceived as people who are in the front line to help. This is my suggestion. Try to be always in this helpful condition, to be picked in this way by families and patients. So I think this is the way in general.
Thank you, Juan. That's very good. Particularly about acknowledging our own uncertainties and feeling comfortable with the discomfort of that. I think that's very important.
That's it. Yeah.
Weng, would you like to add anything to that?
I do agree with Juan. A lot of it is really how we communicate. And actually some of it is also teaching our patients how to communicate between each other. We're all in these isolated households, and I can imagine that, you know, within a family that people are getting on each other's nerves quite easily because there isn't enough space, there isn't enough time apart. And it's actually teaching our patients sometimes how to actually empathize with each other as well. You know, this tolerance is quite difficult. I think having, you know, a routine and a structure in the day, so using some of those behavioral activation techniques to, you know, to have a routine, but also to really schedule in something positive, you know, something, you know, I know that I'm very big into pets, and I know, like in Hong Kong, as well as in New York, pet shelters have all become empty here because everybody's gone to adopt a dog, and it becomes a nice family activity. Other things, you know, sort of promoting family well-being, not just individual, you know, well-being is, you know, just doing some cooking together, something, you know, unifying and bonding. I put all this under, you know, behavioral activation activities, that you get something done during the day that you needed to get done, but you frame it in a more positive way so that there is some enjoyment, you know, so that it's a sense of community even within your isolated household. But, you know, very much like what Jill has been talking about, I do practice what I preach. You can see my flowers in my background. I started doing floral arrangement during COVID for my own, you know, my own well-being. I socialize. I've never socialized, I have to say, so much on social media as I have since March. You know, I can't be physically close, but I can be still socially connected. And all these things you can structure into a day, like a behavioral activation chart, you know, just to give you some structure to help. And I think that helps to build resilience.
Thank you very much. Kim, any thoughts?
Well, it reminds me of the importance of resilience when we speak to populations who are not native, for instance, to the United States. So if you're dealing with asylum seekers or refugees, the enormous resilience that they have for what they have come through already, and then to remind them of that and have them remind you of other things that they have faced. I think we often underestimate the true value of resilient methods and the collective societies that many individuals come from. And I think to focus on collectivism rather than so much individualism at times is very helpful. We are in this together. All of our ads are showing that, but there's still elements that want to break away and do it their way. But this is not the time for that necessarily. So that's what resilience made me think of.
Yeah, thank you. And Jill?
So I have nothing spectacular to add to all of that wisdom from the other people. But I would like to say that I personally think it's important to document the positive things that you've found, the positive things that you're dealing with. Because on a very bad day, these days can be very bad because they're often lonely days. And we all have a tendency to say the whole of life's going to be like this. It's going to be awful. It was awful yesterday and the day before. But if you've written it down, you can say, hang on, I wrote down what was good about yesterday. And you can read it and remind yourself what was good about yesterday. Or you can have a photo of your flowers, or a photo of your dog, or you know, a screenshot of your book club to remind you that yesterday wasn't as bad. And so I think building up a portfolio of positivity is actually a really important thing at this time, because we can easily spiral down, and we need to find ways of spiraling back up using the emotional resources and the positive psychology techniques that you've all talked about, but also using so a gratitude diary or a photo portfolio or something like that.
Thank you very much. I'm going to draw us to a close now. There's a couple of other things come up on the chat from Jose Miguel about artificial intelligence and machine learning, but I think that's a really important one, which Jose Miguel, if it's okay, we'll pick up and respond to you over the next couple of days when we've had a chance to think about that. And a political point from Rick, which I couldn't possibly comment on, but I agree with totally. But I just want to leave it there and to thank Per for making the technology work. To exactly what time, but you'll get the link on that. There will be, and one beer. That's an hour later than this one was. The Special Interest Group on Palliative Care will be providing some insights into that also extremely important part of work. So I'm going to say thank you to everybody now. Thanks to all of you who've been joining in, whether on Facebook or on Zoom. Thank you to everybody who will be joining in the future when you log in and look at this in retrospect. I hope you find it interesting. And once again, thanks to our 4 panelists who've been just wonderful. So goodbye from all of us. Bye for now.
Bye. Thank you.